Good morning. So nice to be with you all this morning. Today I'd like to present preliminary findings from some of our studies about acute and long COVID, particularly as related to themes around diversity, equity, inclusion, and dovetailing just off of our privilege acknowledgement. I'd like to start by recognizing and thanking the truly wonderful team behind this work, as well as my colleagues in the fellowship for their feedback on this presentation, and the Department of Family Medicine for funding our small grant. So as we all in this room are acutely aware, COVID-19 has disproportionately affected some communities. And this trend is projected to continue in the still emerging epidemiological landscape of long COVID. Racial and ethnic minorities, immigrants, people living in larger households, essential workers, people making less than $20,000 a year, all have greater COVID exposure and experience discrimination and COVID stigma in their care. This figure by Berger and colleagues from their recently published paper, Long COVID and Health Inequities, the Role of Primary Care, powerfully elucidates some of these multifactorial underpinnings we see under some of these disparities. So our team was particularly interested in looking at issues around racism and privilege as they relate to access to care, trust in care, and so we aim to explore people's experiences of acute and long COVID with a particular focus on the various identities that we all hold. In this project and in much of our work, we use database of individual patient experience methodology, or Dippix methodology, which is an internationally vetted qualitative research method focused on rigorously eliciting heterogeneous perspectives, synthesizing what we hear through theme and variation, and then amplifying the findings from patients' narratives to inform system change. This involves a true commitment to maximum variation sampling, in-depth interviews with our participants that can last 1, 2, sometimes 3 hours, and approaches to analysis that are truly inductive. So because we were interested in questions around identity, we added some questions to our typical interview guides from the Cultural Formulation Guide. And this was brought to us by a member of our National Health Experiences Research Network Patient Consumer Advisory Board. These questions start out by asking people about aspects of their background or identities that are important to them, followed by aspects they feel like make a difference in their health and healthcare experiences. We then ask some specific questions about people's interactions with healthcare providers and their experiences advocating for themselves in their care. All of our sites within the National Health Experiences Research Network are currently using this set of questions in studies we have in the field. I'm very happy to talk more about our experiences using them should you find that useful in your own work. So combining participants that we interviewed for an international COVID study that's taking a comparative look at experiences with acute COVID and the participants for our long COVID project, we've spoken with 22 people and have one interview tomorrow. You can see here some of the demographic characteristics of this group. We were not as successful as we had hoped in recruiting participants, particularly in speaking with people who identify as non-white, which is a very key direction for some of the future work that we're planning that I'll touch on at the end. So to really center the preliminary findings of this analysis, I'd like to start by sharing a couple of clips with you from some of our participants. And there will be about 2 minutes of 3 participants that you will hear and see. And then there's one participant who preferred her recording not to be shared that I will read aloud. So you will hear about seeking care, about describing long COVID symptoms to providers, about privilege and effects on access to care, and finally from a person of color who's reckoning with her intersectional identities.
I told this person, what my symptoms were, and initially she wasn't going to test me. She's like, oh, I don't think, it's only been 24 hours. I don't think you have COVID, even if we test you. I'm like, just do the test, right? And so it literally took 2 minutes for her to come back in that room and say, oh my God, I'm glad we tested you. You are positive. And that's sort of what I meant, or, what I felt, right, is that it was sort of this, you're ignoring me because I look like crap. You're ignoring me because I'm in a hoodie and sweatpants. You're ignoring me because, I'm Hispanic. You're ignoring me because, what have you. I shouldn't have to ask you.
Most doctors, I'm like, I could give you some feedback, I think, on bedside manner or how you engage patients and like as a partner in healthcare versus sort of talking down to me in a very patronizing way. And I think things like being young, being a woman of color, maybe, all have influence in how doctors have interacted with me. So I'm very not into that. I think I come in you're going to help me and engage me as a partner in this, or I will find another doctor.
I'm a white woman, college educated, make 6 figures, live in the suburbs, have health insurance, have all of the things. COVID especially highlighted how disparities in outcomes in the most vulnerable members, which are not me, right? I'm none of those things. Were the people who disproportionately shared the burden of this disease. So, perhaps my identity, perhaps that also colors a little bit my stop complaining about your smell problem. Just that I have so much privilege that I'm in this world with so much given privilege.
I told this person.
I live in a low income to middle neighborhood. This neighborhood is the essential workers. I always hate separating things by race and ethnicity, but for the lab that I work with, I'm pretty much the only minority. And of the entire group, I'm the only person who got COVID. I'm also the only person who knows several people who died from it and whose inner circle was affected by it, my friends. And sadly, a lot of my friends have long COVID symptoms. Makes me angry sometimes because all of these people are individuals who fall into minority groups versus my white friends are not complaining of any of this. So I hope that you found those clips to be powerful and that we might return to reflecting on them together in our discussion in a couple of minutes. I'd like to elaborate on some of the preliminary findings that we've heard in these interviews, starting with this inner circle of the self. People have reflected on their intersectional identities and how they conceptualize their sense of self and their sense of the future after experiencing acute and long COVID. As you saw in the longer passage that I just read, people have felt more personally connected to systemic inequity, particularly people of color who live at the margins of systemic disadvantage and privilege. We've also heard about deep social divides within communities, experiences of stigma, reflections on who gets COVID and why. And finally, there have been stories about healthcare experiences, people feeling trust in or trusted by their healthcare providers, and people feeling like seeking care in a diverse area was 100% necessary for their health, including the sobering experience of one person who drove 3 hours with pneumonia in order to be admitted to a hospital in another state where he felt like he would receive better care. So this really speaks to the increasingly recognized concept of intersectionality. People who have identified as highly educated and middle class fearing for care mistreatment because of their race and ethnicity, people with societal privilege experiencing guilt, accessing care for stigmatized symptoms, and people reckoning with whether to use their sources of privilege, whether that's education or occupation, to access care that would not be available otherwise to those in their communities. And so as clinicians and researchers, we must increasingly think about an open dialogue around how to attend to intersectional identities in the care and research that we do. To just wrap up with some next steps for this project, we are finishing up interviews in Wisconsin with people who have experienced long COVID. Should you happen to know anyone who might be interested, we'd be very happy to have them connect with us, and our study email is on this slide. We are working on a paper with our colleagues from the UK, Brazil, and Canada that will focus on these questions around diversity, equity, and inclusion for a special issue of Social Science and Medicine's new journal, Qualitative Research in Health. We're also planning a paper with some of our national data, taking a feminist lens to really contextualize people's long COVID experiences within a longer history of stigmatized conditions like chronic fatigue and chronic pain syndrome. And then looking towards some more grant writing in this area to really focus in on equities and long COVID, and begin co-designing health system and mobilization intervention to try to tackle some of these disparities. So with that, I'd like to invite any questions or comments you might have or reflections on these or other questions. Thank you so much.
Thank you, and we have just over 8 minutes for conversation.
Yes.
Jane, I'm curious, it's a theme that just comes up over and over again as I listen to folks who are fellows, but also more advanced people in their careers, talking about the challenges of recruiting research participants who are diverse. I wondered if you might tell us a little bit about the methods that you tried to use and anything that you found successful or that didn't work for you, just to share for the rest of the audience.
Yeah, it's a great question. So for recruitment for this project, we work with REN, the Practice-Based Research Network, through their primary care clinics. And one of the things we realized, and that feels like a finding from our recruitment challenges, is that a lot of people are not presenting for care, or not accessing care, not telling their primary care providers about their long COVID symptoms for a variety of different reasons. And so, though for this small grant, we took sort of a clinical approach to recruitment, as we think about other grants, really a more community-based strategy would probably be more successful. We have had some conversations with community health worker networks around potentially partnering in recruitment. And similarly, they talk about not seeing or not hearing as much about long COVID yet. We think we might be a little bit before the tide as acute COVID is so still prominent. But thinking about ways of sort of recruiting people who are experiencing long COVID symptoms, even if they're not self-identifying or presenting for care. Good question. Other questions or reflections you'd like to share about CLIPS or any of the findings?
Can you say something about the feminist lens paper that you're contemplating?
Yeah. So as you could see in our demographics, we have a predominantly white, predominantly female, and sort of middle-aged sample. And we are sort of thinking about positing in this paper that there's this long history of stigmatized conditions that women have been very much involved in sort of codifying and mobilizing around chronic fatigue and chronic pain syndrome as just two examples. So while there's this stream of narrative around long COVID as being this patient-made illness, there are also all of these other experiences of people being denied, of people fearing to seek care because of the discrimination they may face because of their gender or not being believed. So sort of taking a bit of a historical view to situate some of the findings that we found given who we ended up speaking with. Yes.
So the Dippix approach is a very structured approach for getting a wide variety of input and information, which can really result in a lot of very useful educational materials as well. So, for example, there have been Dippix modules in depression that have resulted in training that have been incorporated into our medical school training. So I wonder if have you thought about learning from this experience, using these sort of modules also for educational activities, for students or other residents or other programs? And if so, how?
Yeah, it's a wonderful question, and we're actually applying through ICTR for some grant money that could sort of fund dissemination of some of this information, taking a very similar approach to with the depression model of using this translational research tool that's called the Catalyst film, sort of a short film that contains clips from interviews as well as some other information that could be used for educational purposes. So very much interested in pursuing that line of work because this is so novel and because patients are really the experts in the space in which we still know very little. Thinking that's a really powerful use of these narratives, particularly in education, but also sort of connecting with long-COVID support communities that have not been that diverse in the people that they have attracted, and thinking about are there ways that we can make those more heterogeneous through sharing some of the narratives of people who might be non-white or have not have as much privilege as some of the people we interview. Yes.
You know, most studies of all sorts present demographics as you identify as this gender. We had this many participants who identified as that racial identity or that linguistic connection or whatever. What you've pointed out is you're different if you're that plus that plus that plus that versus if you're that and that. And that's what intersectionality is about. And we don't capture that really in studies. What advice do you have for people who are presenting demographic data, as you did at the start, in their research to really capture these groups? Because we've seen how distinct that experience is.
Yeah, it's a really important and wonderful question. And it is so tricky when demographics are sort of reported in tables and there's not that space to kind of expand. One of the things that we've really liked about the Cultural Formulation Guide is that it puts it immediately on the participant to reflect on aspects of their identity and sort of bring what is important to them. And we've gotten all kinds of different answers to that. Some people talk about their roles as parents, some people talk about their heritage, not just sort of the typical race, gender, education, occupation that we sometimes hear. It is a really great question that I don't know that I have a good answer to, but I think opportunities to, in your presentation of the data, when you're kind of introducing your participants, to really think more fully about what all of their identities are, rather than just labeling them as a patient or a provider or by gender or by race, to really think about what are all the things that I learned about this person that really need to be here in order to contextualize what they said. Great question.
One of my unpleasant duties is to keep us on time, so I'm gonna do that. And thank you very much.